we have with us Dr. Suresh Ramodran, who's a consultant endocrinologist at Sri Ramakrishna Hospital, Coimbatore. And he has over 20 years of expertise in endocrinology. And to his credit, he has got various academic achievements during his clinical training. And he also has been awarded with the Donald International Scholarship during the Rising Star Award program. Over to you, Dr. Suresh. He is here to be making a presentation on hypopituitarism in Indian perspective.
So, good evening, everyone. Thanks very much for the wonderful opportunity. I think it is nice to be following a big man, Professor Karim Mir, and it's a really honor for me to be following him. So I want to give you a perspective of India with hypopituitarism. So the challenge is the data. I think we were talking about it earlier, but the data in India with haphazard of pituitary cases pitching into neurosurgeon directly and to endocrinologist, to general physician, that's a huge challenge, and it's not like a national health service. But hopefully we will be doing something in terms of getting the data. Now, with that one, I think I want to just go through very quickly with what I can in this for 20 minutes or so. So hypopituitarism, just for the general practitioners and the MDs, I just want to refresh with the starting. It is a condition where Indian data prevalence is almost like a pituitary disorder, 4 million, and we don't know exactly how much hypopits are there. I will come up with some data that is been published actually. So it has to be almost 75% of damage has to happen in pituitary to have a significant impact. And the common conditions is pituitary tumor, for example, is the major thing, and other conditions, I will come to that in a minute. So these are the things that gets affected, growth hormone, ADH, and also with about the mass effects of a tumor, a bitemporal hemianopia is one of the clinical findings. So you go with hypothyroidism, there's some clinical findings will be there, may not be everything is there, but thinning of hair, delayed reflexes, and adrenal, again, the buccal pigmentation. I've seen a patient day before yesterday, he's got this, but hypogonadism is possible. You have to look very carefully in the context of the presentation. So if you got a pituitary apoplexy or something very acute, you may not be able to get it. So these are the differential diagnosis, but I think you can just work out whether it's acute or chronic. But as I said, it could be directly relating to the pituitary dysfunction or a hypothalamic damage, but it can be an isolated pituitary hormone deficiency, and with other pan-hypopit is also not uncommon here. So as I mentioned, the common causes in the global perspective is idiopathic and pituitary tumor, Sheehan's and subarachnoid hemorrhage, and chronic granulomatous diseases, and even the COVID. There are 1 or 2 cases reported, but I think we have to watch the space. And with new drugs of bio drugs, that is also causing hypopit. So India, this is the data from Army Hospital. You can see the macroadenoma was the main culprit, and apart from that, the supracellular tumors like cranios and other things. But the familial and hypophysitis are all very rare. Probably this is underreported. That is my feeling. But empty cella, I've seen in my clinical practice quite a few. I'll come to the interesting aspects of today's talk, which will be the snake bite and other things, which is not uncommon in India. So the vision disturbances and pituitary apoplexy or the presenting features. With a severe headache can be a presenting feature when it's an acute presentation, and secondary amenorrhea. And I'll show, if I get time, I'll show a few cases. That is the way they presented. But failure of lactation and other things of Sheehan's is not uncommon. So hypogonadism and hypothyroidism, these are all the spectrum of pituitary issues that has been presented with that study that has been published in IJEM in 2012. So you can see the male sex is more common compared to the female sex for a change in endocrine diseases. So the pan-hypopit is more common in male as almost 72%. So the treatment approaches after a gamma knife or a radiotherapy or a surgery, you can see the way other hormones of thyroid and gonadotropins and other things. So this is the case I was talking about 3 days ago. Guy presented to my clinic. He's 23-year-old, showing absent secondary sexual characters, micropenis, descended testis. He's still waiting for his MRI, but so he was already on a thyroxine replacement. He presented to urologist, and this is the blood test. You can see clearly he's almost like a pan-hypopit. However, IGF-1 is not there, and as I mentioned, that MRI is still in the process of working out. Cost was the issue, but hopefully that'll be done this week. So the whole idea of presenting this case is it can be a very late presentation at the age of 23 as the initial presentation of an hypopituitarism. So to have an Indian perspective, I think practically there can be cases that is being neglected and present in the later stage. And again, if you come to the second case of mine, which is like 2 months history of nausea and recurrent vomiting and dizziness and weight loss of 2 kg, cataract is 2 weeks ago. The temperature was slightly in the lower side, but it is normal. There is 20 millimeters of blood pressure drop, and you can see the sodium was in the lower side clearly. So the 2 admissions previously with IV saline, and for vomiting and GI symptoms, scopy was normal and ultrasound was completely normal, and osmolalities were done, and glucose is 104, the sodium is 120. So if you look at it, the further test, it shows cleanly that it is a pan-hypopit and with bitemporal visual field defects, and that is a clear case of a pituitary tumor that is causing bitemporal hemianopia. So hydrocortisone and thyroxine and sodium was 140, and TSH, which is the transsphenoidal hypophysectomy, is done. We got an excellent surgeon in our hospital, so who did the thyroid transsphenoidal hypophysectomy, and that brought this result of post-op visual fields. So to say the second case, the pituitary tumor as the common cause in India, and that is the whole idea of the second case. And the third one is a case of a 59-year-old found unresponsive in bed with cold intolerance, and the temperature is 95. You can see the blood pressure, it's in the lower end of normal. So initial diagnosis for hypothyroidism with a TSH of 1.4 and free T4 of 0.32. The further investigation confirmed almost like a pan-hypopit with even IGF-1 in the lower end of normal. So that showed, you can see a slight pituitary tumor with a central darkening, which shows more of a pituitary infarction or an apoplexy, or a small bleed inside the pituitary adenoma. So that is the case that is being presented. So so the 3 cases what I've shown, initially a guy present as a late presentation, and second one is a pituitary tumor, and third one is probably a bleed inside the tumor and causing pan-hypopit. So we, when I was in UCH, we did a couple of case reports with one case of recurrent lymphocytic hypophysitis presenting almost like a pan-hypopit. It's an African lady presenting with multiple episodes of huge tumor of lymphocytic hypophysitis causing pan-hypopit. So the pregnancy was even a challenging one. So this is a very interesting case that we got in British Endocrine Society conference. And the point of lymphocytic hypophysitis is it is very much a steroid responsive tumor, and it responds very much beautifully to the corticosteroids. And the next one is a very, very interesting case. When I was a specialist registrar in University College London, had a case in the evening rounds at 4 o'clock with Addison sort of picture. And it turned out that is a 62-year-old Sikh man, initially presented. He's known to have autoimmune pancreatitis, which is Ig4 infiltrate. You know about it. It's normally misdiagnosed for a pancreatic tumor. But I think autoimmune pancreatitis is an Ig4 infiltrate. And this guy was on azathioprine and a steroid replacement, and presented like this to emergency. The cortisol level was 26, and we normally discuss all the cases that comes to UCH as an on-take the next day morning. So when we discussed, there was only few people that thought that we should go for an MRI. But what happened is the MRI of the further blood investigation showed almost a pan-hypopit picture. It's completely flat, all the hormones that is secreted from the pituitary, and it shows beautiful lymphocytic hypophysitis that has been shown in the picture, and that is more clearly indicating the IG4 infiltrates that is going up to the pituitary. So the point is, any autoimmune disease or a chronic granulomatous disease which can damage the pituitary for almost 75% can have a change in the pituitary gland and the hormone production from the pituitary. So this case shows an extra pancreatic manifestation of an autoimmune pancreatitis, because in this chap the steroid was slightly reduced, and that is the reason that he got precipitation of his crisis. So the case 5 of mine is a 40-year-old patient admitted in the ICU with a hemorrhagic shock due to postpartum hemorrhage following a normal delivery at home. So, and the patient presented with tachycardia of 120, and almost we transfused 5 units of blood, and then administration of hypertonic saline also happened in ICU setting. But the hormone profiles, including the cortisol and quite a few other hormones, everything showed clearly it's a pan-hypopit picture. That is, next to postpartum, obviously the diagnosis is Sheehan syndrome, and that is confirmed by pituitary and cerebral MRI, which showed empty cella as well. But as you know, the Sheehans can be presented acutely and slightly in the later picture, and it's a sort of vascular thing, vascular changes that happens in the pituitary. And these patients' relatives or become once you got the diagnosis and started treating the patient, they were become, what do you say, like your patients forever. You know, they bring the whole family to you. So that is what India is all about. Once you treat them, they just become get the diagnosis and treat them, you become a huge fan for them. So just for the GPs and the practitioners, Sheehan's as a whole is encountered mostly following a severe postpartum hemorrhage, and it's almost 2.5 to 4%. That is a study that is conducted in India. I'll come to the data. This is done in Kashmir by our previous endocrine president, past president of Endocrine Society of India. I'll come to the data in a minute. So normally the patients will presented with lactation, amenorrhea, and genital and axillary loss, and it can present with the circulatory failure because of steroid loss, and severe hyponatremia, and diabetes insipidus, and congestive heart failure, and psychosis and other things. I had another patient who presented with complete postpartum psychosis. She neglected the baby and she was withdrawn from the family, and the huge change happened with the family members. So this is the picture that clearly showing a schematic representation of how Sheehan's happens, and it can damage all the organs in the body of endocrine wise. So this is the data I'm talking about. I spoke about, which is published. It's 279 patients that has been studied in a Kashmir Valley. Professor Abdul Hamid Zargar, he was our 4-5 years before he was the president of Endocrine Society. 4-5 terms, I should say. So this is the data. It shows more of lactotroph failure, gonadotroph failure, and corticotroph failure, and thyrotroph failure. It all happens. But I think there is a possible mechanism was explained in this study. And this is one of the studies that it's amazing that they could do in a Kashmir Valley with the resources, whatever available. And when it's got published, it was a really just eye-opener. Study. Dr. Murthy and Dr. Sundararaman were active members at Endocrine Society at that point. Now, IJEM, another study that has been done by Dalmia Sanyal. This is the Kolkata group that's presented that clearly showed that the clinical features of Sheehan syndrome are often leading to we don't have just set symptoms that is present in Sheehan's. And this study shows that we should be extra vigilant and more careful in diagnosing the patient. So this is from the Bangalore Ramaya University. You can see It's frequent cause of hypopituitarism in underdeveloped countries, and we should be having a real opening of our eyes in patients who are not doing well postpartum. So my last case of today is case 6, which is the 42-year-old man, 10 years history of generalized weakness, lethargy, and facial features, and reduced libido and reduced socialization and depression. So you can see why I showed that's a 10-year history, because things can get missed anywhere in the world for that matter, but because of the health system, it can get missed in India in a big time. I mean, even it happens in NHS, but the challenge is here, a patient end up with different doctors most of the time. So acute illness following a snake bite 15 years ago, at that time he had a renal failure and dialysis. Following a snake bite, he was managed by general physicians for a while with hypothyroidism and levothyroxine. But this patient, interestingly, levothyroxine dosage was adjusted so many times, and this been overlooked for almost 10 years. So when we did the study, you can see that levels of free T4 on presentation of OP is 8.6, but before that it was 1.8. L-troxin was started. ACTH levels are 6.10, and cortisol is almost nothing in the body. And it's amazing how these people will go on about for a very long time. And growth hormone, IGF-1, all are almost causing complete pan-hypopit. So this case, when we did the MRI, it shows an empty cell, and steroids were started, testosterone was started, and DEXA bone scan was started. This is to show clearly. I mean, I had almost when I was working another place, which is Kobe Medical Center, and this place together, I had almost 7 cases that I managed. In the whole hospital, there was more than 20 cases of viper. Viper snake is the one which damages. So the out of the 7-8 cases of mine, 3-4 presented more acutely, and they dropped the blood pressure and everything. So snake bite, in my experience and the data what is presented, it can presented acutely, or it can present in the later stage, like this case, very later stage, so that it's very difficult to diagnose. So it's a patients with vasculotoxic snake bite. This is presented in the IJEM on the pituitary journal. So it shows clearly we should be suspecting a pituitary damage when a snake bite patient enters into the casualty, number 1, and number 2, unexplained blood pressure drop or anything, should suspect that. And third, if the patient is deteriorating in spite of treatment, we should suspect that. And then fourth, when they come for follow-up, we might want to do a pituitary blood test. So this is the study that showed with each case what happened, and it's very, very fascinating data. And if you see, the pituitary dysfunction is variable, so it's not clear-cut with all the patients together. And normally it causes party empty cella, like what Sheehan's can happen, like more of a vascular phenomenon. So again, this was published in Nature 2018. You can see the 8 cases being analyzed properly in this study. I'll just skip through, but the important point is we have to do a workup like what we normally do for a hypopit or any pituitary case. So there was explanation like more of fibrin deposits in the pituitary blood vessel, and hypoxic and ischemic damage contribute to the hypotension that is being caused. So other causes, as I mentioned, the pituitary apoplexy is another one. And in India, another condition is a TB, which can produce a very surprising amount of pituitary damage with an abscess, or even as an extra lung manifestation of a TB. So our just immediate past president, Dr. Sanjay Kalra, has done a good work on hypopituitarism in tropics. It's an interesting paper to read in IJEM. Please go through that. So I just want to summarize in my 20 minutes of talk. So the most common hypopituitarism in India is a pituitary tumor, and the complaint is the visual symptom, and pan-hypopit can be presenting as the common presentation. And Sneehanch and snake bite is something that you should not miss. So the first case I shown is a late presentation, and the second one is a pituitary tumor, and third one is an hypopit, which presented secondary to pituitary apoplexy. And then the fourth one is the lymphocytic hypophysitis, which is my personal cases that I've seen in UK. And then the fifth one is the cases from Sheehan syndrome, and the sixth one is the snake bite. So these are the things that we should keep in mind apart from the commonest pituitary tumor. So I'll stop there. Hypopituitarism need to be diagnosed and treated as a teamwork, and that should happen in India as well. I stop there. Thank you.
Thank you, Dr. Suresh, for your excellent talk and bringing in the relevance of PPH, snake bite, and tuberculosis in the cause of hypopituitarism in Indian context. I have a question. What is your experience on the impact of the ongoing pandemic on the HPA suppression? How often are we getting hypocorticolism? How often are we encountering hypopituitarism in routine day-to-day practice?
Personally, I haven't seen one, but I've seen the data. Professor Karim Miran can come in with the data if he is also very active in the Pituitary Foundation. In India, I think there are haphazard reports of the cases, but there is a definite impact with probably biodrugs being used, and also with the virus itself. There are high chances of this happening, and the case reports are there. Even the thyroid is mainly affected as well. So I'll let Professor Miran to answer if he knows anything more.
I think we are certainly seeing patients who have crises needing a bit more steroid. We've done some studies looking at levels of COVID patients. They have higher levels of cortisol if they have not got adrenal failure. So it looks like they do need a higher dose. And so that's what we're doing. Can I ask another question? That was a really good talk, Suresh. I have to say, I'd really like to involve those last two patients, your Sheehan's patient and the snake bite. I mean, you've got a unique population of patients that could be studied if they're on high cortisol.
There is Sri Lanka. I'm in touch with South Asian Federation of Endocrine Societies. We got a group, and when we presented in one of the meetings, and they said even in Sri Lanka, it is very, very common to have a viper bite following that hypopituitarism happens. And as I mentioned, the previous hospital I worked in, there's so many snake bite. The people just bring in a snake along with them, you know. So, so the viper is the main culprit. But it's amazing data that needs to be collected.
Yeah, what is more amazing is the cortisol was 0, and I agree it's amazing. And it's probably because the adrenal is okay, so they have aldosterone, so they survive without a crisis.
That's what it is.
But it'd be very interesting to see if prednisolone is different, because your patients, one is on 40 of hydrocortisone. Now, for her, the 40 of it'll be quite difficult, because when you cut to 3.75 of prednisolone, they will feel the symptoms of reduction of steroids if they're used to 40. So that needs, is that 20-10-10, or how is that administered?
Yeah, it is 20-10-10. It was initially managed by, because it's a long story, it has been a long story. So I picked up in between, but yeah, so it is a huge challenge to reduce the steroids in this case.
It is a real challenge. I have the same problem. A lot of patients here are on that sort of dose. And when you reduce it, they get unhappy and they don't want to take part in research because they say, oh, this is done well. So there is a challenge there for us all.
So in Hammersmith, probably they just come in and they probably delay their presentation. But in India, they change doctor next minute. So they won't be happy at all. They got plenty of choices.
Yeah. But, And Dr. Suresh, we have a question from Dr. Prerna. Could you please tell us the timing of each hormone to be checked if we don't pan hypopituitarism?
In India, the main thing is just to check all the hormones early in the morning. You cannot give any other option to them because they travel from long distances and everything. For practical purposes, just early in the morning, about 7 to 8-ish, that is the right time to do the hormone profile in India, practically.
I think it's the same in the world.
Yeah, okay.
Dr. Suresh, I have one question. Actually, what is the reason for a delayed that partial empty cell following a Viper bite? Whether it is being missed at the time of Viper bite, they are not doubting the doctors who are treating the patient or the patient. What could be the exact reason? Because that whatever the Sivaprasad who has published that article also, there are so many delayed presentation of Viper bite is being identified. Even in Jipmar also, we see some of the case recently. I have seen one case following 15 years, where the patient is being treated by somebody with only L-toxin or something like that. What could be the reason?
So the two things to it. One, they initially, when they have unexplained BP drop, we should suspect it. And we don't know how many of the snake bites initially dying, not diagnosed of a pituitary disease. That's number one. And the reason for the later presentation, we think it is probably antigen antibody reaction. It's more of a Sheehan sort of picture as a late presentation. That is the possible explanation. That is, it is like more of a Sheehan's sort of syndrome that is presenting after a snake bite. Have you got any other explanation, Dr. Malaburgeshan?
No, actually, no. I have seen one patient actually 15 years after he came with vomiting and hyponatremia. Initially, we were working for that dysalcoholemia. Then subsequently, we got a history from the patient that he had a old record of Jipmar, and that time itself they found some partial empty cella. But I think the patient missed to follow up also. But I don't know how the patient survived for 15 years without a proper treatment.
This is the thing that Meeran was explaining. Probably the fludrocortisone from the adrenal is helping a bit. We don't know.
Maybe.
Mineralocorticoid effect could be the reason. But this is the place where the whole world look into place like India, because in Western world, we can't expect the data like this. So probably we were discussing in ESTN and few other societies that these are the areas that we can join together as a team and do this thing. But we are in the process of doing it. So hopefully.
Yeah, better that I think we are like what you told. We need to look every Viper bite patients who develop unexplained hypotension, and carefully we follow up the patients, and we can find out much more number of these pan-hypopituitarism. I hope so in future.
But it is, even though it is episode, we can do it because the volume is quite straightforward. We know that where the dialysis centers are in India, we can tap it and do it because it will be a huge volume if you do it. And it's a good data to even publish in a textbook, you know.
Yeah, the only problem is like, madam, that the cost of all the hormones, but that will be much lesser compared to the treatment. If you tell.
Absolutely.
Lokesh, you can conclude.
Can I ask one question?
Dr. Sundaraman, Professor Sundaraman, please, sir.
Yeah, it was very informative and very good outlook about hypopituitarism in India. Some of the observations that I've also seen a lot of snake bite. As you said correctly, the Russell's viper is quite common in India. And these patients have more of glucocorticoid deficiency apart from other pituitary hormones. In fact, their thyroid, everything is normal. That's why they just pull along with that with a mild adrenocortical insufficiency, the glucocorticoid deficiency. And that is why only if you are stressed, they go into hyponatremia and other things. That's why you get a lot of these cases where they miss the snake bite and they come after a long time with a glucocorticoid deficiency. Another important thing that I've seen that for replacement, if you give for in a hypopit and an adrenal failure, the psychiatric manifestations are quite common if it is hypopit causing glucocorticoid deficiency compared with the adrenal causes causing glucocorticoid deficiency. Why is it different?
So it is your observation, but I haven't got any personal experience of hypopit is isolately cause depression and other.
No, the more common of a psychiatric. If you give steroids in Sheehan syndrome, they go into psychosis. Sometimes, most probably, most frequent.
So what they say is, Dr. Meeran can answer, but postpartum normally. The Sheehan's, what I had one very interesting case, she presented postpartum psychosis alone. 6 doctors have seen her before, and they couldn't just pin up everything together. She ended up in your hands. But before that, she was almost about to get divorced, And because after the newborn is isolated and staying in separate rooms, she doesn't lactate. She just got disinterest in life. She's the only child of the family. It was a nightmare, and she goes into psychotic episode. That is a personal experience that I had with the Sheehan syndrome patient. But whether the cortisol deficiency secondary to adrenal and pituitary is different in causing psychosis, I don't have a personal.
Not the replacement. If you replace them,
okay,
they go into psychosis compared to the glucocorticoid deficiency of adrenal origin. I don't know why it's like that.
Steroid. Sir, I personally don't know. I'll accept that I don't know. Dr. Miran, any experience?
No, I don't know either. I think that's correct. It might be there's just an association because, of course, as you said, there is a risk of postpartum psychosis to the fall of progesterone. But I have no other explanation. So you're wiser than I am on this area.
Okay.
On behalf of organizing team, I thank all the speakers for taking your valuable time and being on this particular session. We can wind up this session. Very good. It was quite a very interesting session by both the expertise from both our country as well as abroad. Thank you very much.
Thank you.
Thanks,
Sir.
Thanks, Miran. We'll be in touch, Dr. Miran.
Yes, thank you.
Thank you, sirs, for an excellent discussion.